Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's August 2022 issue. There are 4 articles that have been selected as our editor's choice or highlights articles this month. The editor's choice is an original article entitled Racial Differences and Social Determinants of Health in Achieving Hypertension Control. It is authored by Dr. Richard Milani and colleagues from the John Ochsner Heart and Vascular Institute, Ochsner Clinical School, New Orleans, Louisiana. Systemic hypertension is appropriately publicized as a dominant, generally tractable risk factor for cardiovascular disease. As non-pharmacologic and pharmacologic approaches in the management of hypertension are steadily improving, one would anticipate that trends in the prevalence and outcomes of hypertension would be encouraging. This, however, is not the case. General awareness of hypertension and its adverse effects is decreasing in the population of the United States, where the prevalence of hypertension in adults is now approaching 50%. The level of blood pressure control in individuals treated for hypertension is declining, and notably, mortality from hypertension-related cardiovascular disease is on the rise. Thus, the question arises, why are there these troubling trends for a condition that is a known harbinger for cardiovascular disease and one for which management is continually being refined? An important insight regarding this issue is provided in the article by Milani et al. In the present issue of Mayo Clinic Proceedings. Milani et al. Undertook a retrospective cohort analysis of more than 3,300 patients with hypertension enrolled by their physician into a hypertension digital medicine program and followed for up to 1 year. Enrollment required the patient having a smartphone and purchasing a blood pressure unit compatible with the smartphone. Interaction and follow-up occurred through the patient portal. Data relevant to hypertension and its risk factors and management were obtained. Blood pressure readings were charted weekly, and doctoral pharmacists and health coaches interacted regularly with enrolled patients. Barriers to healthcare were itemized as 3 main issues: health literacy, patient activation, and financial strain, all of which were assessed for each patient. The primary outcome was the proportion of patients with a blood pressure less than 140/90 millimeters of mercury at 1 year. The findings demonstrate that healthcare barriers were generally more prevalent in Blacks as compared with whites, and that compared with individuals with no healthcare barriers, blood pressure was less well controlled in individuals with 1 barrier, and especially so for individuals with 2 or more barriers. Notably, for individuals with 2 or more barriers, blood pressure control was entirely comparable for Blacks and whites. The latter findings, as the authors discerningly speculate, suggest that overarching socioeconomic disparities per se, rather than intrinsic resistance to blood pressure management, may be responsible for less effective blood pressure control, often reported in Blacks. This timely study by Milani et al. Thus uncovers the impact of social determinants of health and race on blood pressure control, and one which is quite relevant to these disturbing trends in the prevalence and consequence of hypertension. Additionally, informing these findings of Milani et al. Is a broadly relevant concept. That is, for any prevalent disease to be effectively treated, messaging regarding its significance and risks must be clearly communicated. Individuals with the condition need to be successfully and intimately engaged and activated in patient-centric management with healthcare providers, and socioeconomic conditions that impede access to healthcare, restrict medications affordability, and disincentivize patient activation all need to be addressed. Our first highlight this month includes two articles on the prognostic power of artificial intelligence. The first is a letter to the editor entitled Introducing Artificial Intelligence into the Preventive Medicine Visit. It is authored by Dr. David Hammond and colleagues from Mayo Clinic in Rochester, Minnesota, and centers on artificial intelligence enhanced electrocardiogram, which has been shown to reliably detect several cardiac conditions. Using an illustrative case, Hammond et al. Demonstrate how age predicted by an artificial intelligence enhanced electrocardiogram may align with or diverge from a patient's chronologic age. In this case study, an obese patient without any cardiac history had an artificial intelligence enhanced ECG predicted age that exceeded the patient's chronologic age by 5 years. Following regular exercise and an altered diet and weight reduction of 40 pounds over a 6-month period, the age predicted by an artificial intelligence enhanced electrocardiogram decreased and aligned with the patient's chronologic age. In essence, the age predicted by the artificial intelligence enhanced electrocardiogram reflected improved cardiovascular and overall fitness attendant upon healthy lifestyle choices and weight loss. The second article on the prognostic power of artificial intelligence is an original article entitled Prediction of Mortality in Coronary Artery Disease, the Role of Machine Learning and Maximal Exercise Capacity. It is authored by Dr. Cristina de Souza e Silva from the Exercise Medicine Clinic, Clinimex, in Rio de Janeiro, Brazil, and colleagues from several national and international institutions. De Souza e Silva et al. Used machine learning to predict mortality in more than 13,000 patients with coronary artery disease referred for cardiac rehabilitation from 1995 to 2016. In this analysis, 25 features were assessed, which pertain to demographic characteristics, comorbidities, indications for coronary angiography, number of disease vessels, left ventricular ejection fraction, exercise testing, and management strategy. Of these features, age and peak metabolic equivalence emerged as the most significant ones in predicting mortality, outstripping, for example, diabetes, current smoking, indications for coronary angiography, number of disease vessels, or left ventricular ejection fraction. Based on these two features, a survival tree analysis accurately predicted mortality, thereby providing a novel and simple prediction model for survival in patients with coronary artery disease. These two contributions attest to the power and potential of artificial intelligence in medical practice. Hammond et al. Demonstrate how artificial intelligence may refine a simple tool, the electrocardiogram, into one that assesses overall fitness and cardiovascular health, or the lack thereof, while De Souza e Silva et al. Demonstrate the use of machine learning in predicting mortality in coronary artery disease, underscoring once again the importance of regular exercise as a determinant of outcomes in cardiovascular disease. Our second highlight is another letter to the editor that is entitled Impending Arteriovenous Fistula Bleeding with Skin Ulceration, which is authored by Dr. Nolan Cirillo-Penn and colleagues from Mayo Clinic in Rochester, Minnesota. Vascular access provides a lifeline for hemodialysis, and of the available accesses, the arteriovenous fistula is the most favored. Yet this preferred vascular access is susceptible to numerous complications, including, among others, the complete failure to mature into a functional access, the need for interventions to promote maturation, and the occurrence of venous stenosis, thrombosis, hematoma, and seroma formation, and infection. In the upper extremity, the creation of arteriovenous fistula may cause a vascular seal syndrome and quite rarely ischemic monomelic neuropathy. Chronically, the venous wall of an arteriovenous fistula is constantly exposed to vascular stress that includes intermittent needle puncture for hemodialysis and pathologic shear stress imposed by the heightened blood pressures and flows conveyed by the arterial inflow to the arteriovenous fistula. In time, and especially if subjected to a more proximal venous stenosis, the venous wall may become aneurysmal and progressively weaker, attenuated, and ulcerated to the point that bleeding and rupture may occur. This is the most urgent of all arteriovenous fistula complications, because if such hemorrhage is not expeditiously staunched, exsanguination can occur. The remarkable observations of Cirillo Penn et al. Document by video a sentinel bleed from a dialysis arteriovenous fistula that spontaneously occurred during dialysis. The arteriovenous fistula was 12 years old, with complications that included central venous stenosis and the need for stent placement and venoplasties. Physical examination revealed two significant aneurysms, skin attenuation and breakdown, the eddying of blood beneath the broken skin, and the likelihood of incipient hemorrhage. Cirillo Penn et al. Expeditiously repaired the fistula, noting that in the more proximal aneurysm, it was just an overlying thrombus that averted frank rupture and bleeding. 2 months after the surgical procedure, the repaired fistula was once more used for dialysis. This remarkable case of Cirillo Penn is instructive for several reasons. First, it provides one of the very few video documentations of a sentinel bleed from an arteriovenous fistula, one which may presage torrential and life-threatening hemorrhage. Second, it demonstrates how timely intervention by and the expertise of vascular surgery can prevent such a feared complication, as well as salvage and repair the fistula such that it can once more be used for intermittent hemodialysis. And third, it underscores the clinical acumen and attentiveness of dialysis providers and personnel in recognizing the significance of this early sign, in instituting temporizing measures, and in expeditiously obtaining definitive management by vascular surgery. You can access these highlights and editor's choice articles free of charge during the entire month of August. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you will find links to our social media by clicking the buttons at the bottom of the home page, or to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insights podcast recordings, which are available from our website on the home page as well as through iTunes. You will also find our online-only features and many news stories posted in News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content, as well as articles published online in press. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.